Hello everyone, I am Dr. Umar Karadan, Chief Consultant at Baby Memorial Hospital, Calicut. Today I would like to share some aspects regarding hyponatremia. Hyponatremia means low sodium level in the blood. Usually it is 135 to 145 milliequivalents per liter. Once it comes down below 135, you call it as a hyponatremia. If it goes above 145, it is hypernatremia. It's quite common throughout the world. You said that around 30% of the hospital admissions are due to low sodium level. So if the patient comes with some altered sensorium, irritability, seizures and coma, you have to rule out low sodium level because it's quite common, especially in the elderly. The symptoms, because this can be in different ways, manifest in different. This may be a mild form, moderate form or severe form. This can manifest within 48 hours. It's called a acute hyponatremia. If it's beyond 48 hours, it's called a chronic hyponatremia. This may be symptomatic, like the patient comes with altered sensorium, memory impairment, difficulty in walking, recurrent falls, or some irritability, nausea, vomiting. Or this might come as a chronic form where the patient is asymptomatic. They might when they check the blood, then we find that sodium is 125 or 130. So in this condition, you have to see why the sodium is low, because it is very important. Because it's a normal practice that people start giving 0.9% saline, the normal saline for every case of hyponatremia. It's not right, because we have to find out what is the cause of the hyponatremia, because the sodium may be low level may be due to different causes. This may be one cause called a pseudo hyponatremia, if the blood sugar is quite high, or if the triglyceride is high, or if there are certain proteins in the blood called paraproteinemia, the sodium may be pseudo low, because it's not truly low, but if you correct those conditions, it becomes normalized. In the same way, if the patient had a contrast study, like a contrast scan, or had received mannitol, the sodium can be low. It may be due to a hypovolemic hyponatremia, means that the blood volume is low, like if the patient had some diarrhea, vomiting or excessive sweating due to a hot climate and all, the sodium can be low. In the same way, the blood volume can also be low, where you have to give saline. That's a typical patient whom you have to start on normal saline or excessive fluid replenishment, okay, with treatment of the underlying cause of diarrhea, vomiting and other condition. All right. So or if the patient has got some deficiency of hormone called mineralocorticoid deficiency, we have to treat with steroids and saline. The second thing is those with a high blood volume, like in cardiac failure, kidney failure or liver failure, the blood volume will be high and there will be a dilutional low sodium level, where you can give saline, where you have to restrict the fluid intake, because if you treat with saline, the blood volume again bloated up. So the sodium will, instead of from 110 comes to 100. So it is not advisable, where you have to treat the primary condition like cardiac failure, liver failure, renal failure, and you have to restrict the fluid intake. Instead of giving more fluid, you have to give less fluid, and it's better not to give normal saline. If you give saline, again the sodium will come down, and you have to treat the basic condition. A third and most common, around 60% of the cause of hyponatremia is SIADH or SIAD, or syndrome of inappropriate ADH secretion, or euvolemic hyponatremia, where the blood volume is normal but the sodium is low. The sodium may be 80, 90, 100, 110, 120, anything less than 1/3, 35, and they can present acutely with a seizure, or they can present in coma or altered sensorium, irritability, restlessness. Okay, sometimes very rarely with the focal weakness, but usually it is a altered sensorium, irritability, confusion and seizures and coma. In those cases, you have to start the medication. There you have to give some particular concentration of the saline is called 3% saline slowly over 3 to 4 hours with frequent monitoring, maybe 6 to 8 hours monitoring of the sodium, because you can't increase the sodium level fast, though it's possible, because if you increase the sodium level fast, what happens, the sodium, the brain gets some, not able to adapt, and patient will have damage to the brain, some condition called central pontine myelinolysis or extra pontine myelinolysis, where the patient becomes mute with decerebrate posturing and weakness and Parkinsonism. So it is always better to know that whether it is CAD and how the treatment, you shouldn't start treatment fast and shouldn't increase the sodium level from 90 to 100, I mean up to 10 per 24 hours is acceptable, not more than that. So as I told you earlier, 60% of the hospital admission is due to this low sodium due to SIADH. Okay, so we have to monitor the sodium level. We have to monitor the osmolality of what is the serum osmolality, the urine sodium level, urine osmolality level, the uric acid, as well as the your ABG level of what is hypokalemia or acid base disturbance, urea level, blood pressure level, what is the diet the patient is having, whether he has to take more beer, or it is a history of compulsive water drinking, or if the patient has got recurrent low sodium, you have to suspect certain condition called malignancies in the chest, like a small cell carcinoma, pancreatic carcinoma, head and neck malignancy, or a patient may be taking drugs, which is because very common drug is diuretic induced hyponatremia, because people will take certain antihypertensives combined with the diuretics. So these people are prone for low sodium if they don't monitor their serum sodium level properly, maybe once or twice per month. So you have to monitor the serum sodium level if you take diuretics with antihypertensive. Similarly, there are many drugs, antidepressant, antipsychotics, antiepileptics, analgesics, and anti-malignancy drugs like carbazepine, oxcarbazepine, or amitriptyline, clozapine, fluoxetine, sertraline, many drugs. So in all those cases, if you feel like some irritability, confusion, memory impairment, difficulty in walking, recurrent falls, check the serum sodium, because it would prevent a fall and fracture. So basically you monitor your sodium level. Okay, and you have to take a good history, what's really happened, whether it's a recent onset or it's a chronic, it's a symptomatic, asymptomatic, any drugs is causing, is responsible, or any lesions in the lung, chest, or any brain lesions are responsible for the low sodium. And you may have to take a X-ray chest, a CT thorax. Sometimes you may have to monitor your cortisol level, ACTH level, thyroid status, renal function, blood sugar. So you have to do all these tests, and once it is confirmed there is a low sodium, you have to treat. If it's a low hyponatremia due to low volume, you have to treat with a normal saline and more fluid replenishment. If it is a hypervolemic, you restrict the fluid and give diuretics. If it's a euvolemic or normal blood volume and low sodium, restrict the fluid, and we can use certain drugs called vaptans. And if the patient comes acutely with a seizure and coma, we have to use 3% saline slowly, or in all other cases we can use decrease the intake, maybe 500 to 1500 ml per day, and we can use drugs called vaptans. Okay, so my message of today is so hyponatremia is quite common. You can detect it by just observation, any behavioral changes in people, or difficulty in walking, or memory impairment. In those cases, check the sodium, potassium, and monitor for the blood pressure variation. And if it is coming frequently, you have to look for other causes like malignancies, the chest and abdomen and the head and neck, and monitoring for the endocrine problem like hypoadrenalism or hypothyroidism, liver failure, renal failure, cardiac failure. So you have to monitor and you have to treat accordingly. So I hope this video is effective, and it would bring some throw some light on this aspect. Thank you very much. Bye.